My name's Lesley Regan. I'm the Women's Health Ambassador for England, and I'm still doing a bit of gynecology on the front line at St Mary's Hospital in Paddington. And I'm really, really thrilled because I'm also the chair of Wellbeing of Women, and I'm trying to get all those different parts, the clinical, the charitable, and the policy bit, and the politicians, as we have two politicians, and we're very egalitarian here. We have a Labour politician and a Conservative politician. And I've got doctors here, I've got a football manager, I've got fantastically inspirational GPs, we've got the whole works. So we've got a real talent, we've got lived experience, and so many of you women cross all of those categories because you've done it, you've lived experience. One of the things that I was saying to somebody who had to listen to me because I was making a presentation to an integrated care board this morning, you just have to remember that every woman in that room with you, and there are an awful lot, has 12 periods a year for nearly 40 years of her life. And therefore, if she's disabled in some way by them, or she can't function in her job or at school or undertaking her caring responsibilities, we failed her, because there are lots of different ways in which we can help and get women to get on with what they do best, which is organising everybody else in society. So we've decided to launch our campaign at Wellbeing of Women this year is Just a Period, and we want to stop anyone ever referring to it as being normal, to be debilitated by heavy periods or painful periods or problem periods in any other way. So it's not just a period, and it's not normal to be suffering like that. There's lots of things that we can help women with. So we're going to be sharing information and resources, because there's those of you who know me recognize my big passion in life is that if you give women the information they need to help themselves, not only do they usually follow the advice and therefore are able to get on with their lives, but the marvelous thing is that they then go and share it with everybody else they know. We also ran a census or a survey of over 3,000 women during the month of August 2023, which was nationally representative. Women from every walk of life, from every socioeconomic and educational level. And we accrued information that is just so endorsing of all of those problems of the 100,000 consultation responses to the DHSC call for evidence for the Women's Health Strategy. So what we know is that right at the top of women's list of what they want help with is menstrual disorders and menstrual problems. So that's why we're having Just a Period as our new campaign. So my real goal this year is to make sure that we make periods just as fun and important to talk about as menopause has been in the last couple of years. So if between us all we can achieve that, we'll have scored some really good goals, I think. Now, you can see that we've got some fabulous people on this call. We've got Dr. Nighat Arif, Dr. Aziza Sesay, Alice Living, Emma Hayes, Clare Nasir, Andrea Senior, Caroline Nokes, Anneleise Dodds, and Dr. Varsha Jain. So what I propose we do is, rather than me ask you all to introduce yourselves one by one for our audience, I'm going to introduce you to ask you a few questions, if I may, and then perhaps you could just give us one or two sentences about why you're here, why you've joined this call, and why you feel so passionate about women's health, because you've been very carefully selected. So I know you do feel very passionate about women's health, and also what you want to do and you're going to do to advocate for women. So let's go from there. And I'm going to start off, if I may, with Anneleise and Caroline, who are Labour Party and Conservative Party MPs who have been so involved in trying to push the ball forward for women in their different ways. You will know that Caroline has been the formidable chair of the Women and Equalities Committee, and I think she's completely fearless. And I love women like that, because I feel that I think I'm one of them too. So Anneleise and Caroline, how do you want to start? Why are gynecological conditions something that the government needs to be taking seriously? Anneleise, why don't you start?
Well, of course, and thank you. And it's great to be part of such an amazing group of women. I mean, I think they have to be taken seriously, because sadly, currently they aren't taken as seriously as they need to be. I think that the consultation responses show that really clearly for the Women's Health Strategy. And Dame Lesley, it's really interesting to hear that about the recent survey evidence as well. I was interested in preparing for this discussion in terms of why we need to have it. I was actually framing it in a very similar way to how you were thinking about it. I think that we have had that opening up discussion now about menopause. Still, I would say a huge amount that needs to be done. You know, we need to see a really significant amount of change in understanding and indeed in practice, particularly in the workplace, but also in healthcare too. But we need to see that change around periods as well. We need to be talking about them. Periods that are debilitating, that are ultimately holding women back, as was mentioned a moment ago, that is a problem. That's not normal, and that should be sorted, and action should be taken. And I think now, when we see a lot of barriers for women trying to access the support that they need, some really pretty long waiting, unfortunately, various inequalities in access, we need making sure this is right at the top of the public agenda. So, real privilege to be part of this conversation.
Thank you, Anneleise, and thank you for all you've been doing in your role as shadow chair for the Women Inequalities in the UK. So Caroline, your thoughts? I'll just go over those again. So what makes you feel so passionate about this topic, and what are you hoping to achieve in the near future in the Women Inequalities Committee, if that's the bit you'd like to talk about?
Thanks, Lesley. And I was actually going to kick off exactly with that. The Women Inequalities Committee has until tomorrow, and this is a plug for everybody, a call for evidence open for our new inquiry, which is about women's reproductive health. And my big fear is that we're going to end up talking endlessly about abortion and not about periods and about all of the various gynecological conditions that can impact women. So anybody who wishes to respond to that can go to our website and give their comments. And why are we doing that? Well, look, you highlighted it yourself. We've done an enormous amount of work on the menopause, but throughout the course of that work, it became really apparent that there is this terrible phrase, well, it's just a period. Why are you making a fuss about that? Can't you just get on with it? And it is impacting women's well-being. It's impacting girls' ability to participate in school, in sport, in everyday life. And apologies for this. This is very brutal, but this is a stark reality. It's impacting their economic well-being, and it's impacting the well-being of the wider economy. There's a brilliant APPG in Parliament on, and just to pick out one gynecological condition, on endometriosis, that has identified that the cost to the economy of endo is £8.2 billion a year. That's about lost work days. It's about women, 1 in 6 women with endometriosis being forced out of work altogether. It's about promotions not taken. This sounds like the menopause spiel that I give. It's about women missing out on promotions, women leaving work early, women not making pension contributions, women being financially impacted for the rest of their days. And that has to change. So our inquiry is not just about what constitutes healthy periods. We're very interested in that, but it's also, what are your experiences of diagnosis? What are the barriers to treatment? What are the disparities in treatment? And I'm not going to prejudge that inquiry. I could sit here and make a load of assumptions, but that's why it's important, because yet again, we're tackling what I'm going to refer to as ingrained institutional misogyny that tells women to just get on with it, when in fact it's serious medical conditions that are preventing them from just getting on with life in the way that we all want to.
Thank you, Caroline. Thank you very much indeed. I'm going to turn now, if I may, to Nighat and to Aziza. We both, well, you know that we heard from the Women's Health Strategy that women said that gynae conditions were right at the top of their list. And I was really interested about how definitive that was, right at the top. It was the gynae problems. It wasn't the more sophisticated, clever stuff that we so often hear about in our newspapers. It was the bog standard things, that there was the heavy period, it was the pain, it was the problems with fertility, etc. So what do you think that we should be focusing on, and what are your priorities? Nighat, would you like to go first, or Aziza? I don't mind which, but you race in.
So I'll go first. Hello, everybody. And I echo a lot of what Caroline and Anneleise are saying. I'm the ambassador of Wellbeing of Women, but I'm an NHS GP, and my clinics are, majority of them, filled with period-related issues. So that's endometriosis, adenomyosis, fibroids, painful periods or heavy periods, which I don't even have a diagnosis for, because when I refer for an ultrasound scan, there are no real diagnoses. the pathway in the NHS for periods, particularly, is that these are benign conditions. So my patients are waiting for up to 6 months to 9 months. And so they are held within the general practice system, which is me, which means lost work days, which means escalating pain relief. Sometimes with endometriosis, I've seen patients who are being put on morphine or they've gone into A&E requiring morphine. So it's more than just a period. It's the fact that we are drowning within the NHS anyway because of all the issues that we have currently. But on top of that, women don't want to come into general practice for period-related issues. They just want a diagnosis and a solution and not be told it's a benign condition, because the pathways are set up for all the cancer-related 2-week pathways, but it's just a period. So I'm really passionate about this in regards to the fact that we need to change the clinical pathways for allowing us as doctors to feel empowered to look after our patients in primary care. But within that, make sure that the NHS pathway is navigated for those for whom it's not easy to do so. So I'm talking about Black and Asian communities. I'm talking about those from disability communities, trans communities as well, LGBTQ plus communities who are already, these are, as we, myself and Lesley keep saying, these are hardly reached. It's not that they're hard to reach, they're hardly reached, and their voices aren't taken into account when clinical pathways are set up. So on a wider context as a clinician, I'm so passionate about this because we need support, but also to support our women so that we're not losing 8.2 billion of revenue that women are entitled to because of their just a period.
Aziza, you're in general practice too, but I know you've got some thoughts. What are your passions in this, and what are you hoping to achieve?
Yeah, thank you so much for having me here. This is such a brilliant discussion to have, an important one as well. And I echo everything that's been said so far. Yes, I'm an NHS GP, and I'm seeing the side that Nighat's mentioned. One of the failures as well that's there, so she's spoken about the NHS pathways and so on. It's just a lack of education. So loads of surveys have been done recently, and a lot of the times, even basic anatomy or basic knowledge of what's normal isn't known. So education from the patient side. So people aren't aware that, like we say, heavy, painful periods is not normal. They just think, oh, I've always had this for as long as I can remember, so it's not anything that I need to be concerned about, or other gynecological conditions, So when we talk about education and awareness, like that's something that I'm really passionate about, just getting the information out there so people are able to go ahead and advocate for themselves, to push for more investigations to be done, to push to get a diagnosis so they don't continue to live on with this. But we definitely need the help, as Nighat mentioned, with regards to what's available for us as GPs, because you're kind of stuck. You want to support, you want to move forward, but how can you move on to the next step if, for instance, they're having to wait 6 months to a year before they're seen for a condition that, again, that's considered benign because it's not cancerous, but it is stopping them from living. It's stopping them from existing.
Well, that's what the Women's Health Strategy, I think, really highlighted for everyone, me particularly, was it is actually not that these things are difficult to sort out. It's that women don't have access to the services that they need in a timely fashion. And that's one of the reasons that I've really been pushing for the women's health hubs. I don't think it's necessary for women to come to see a gynecologist in secondary care with their problem periods. We should be able to deal with this in women's health hubs that are much more community-based. But what we've got to do is make sure that we're signposting women to the places where they can get easy access to the care they need. And so we're not wasting enormous resource on sending them to place after place where they're told, oh, well, you can have this bit done, but you can't have that bit done. That's got to stop. Now, I'm going to move on now to 3 women on our platform who've got lived experience. Emma with endometriosis, Emma Hayes, who's an award-winning football manager and public speaker and an author, and Alice, who's also a best-selling author and a fitness guru, and she's going to talk about her polycystic ovarian syndrome. And then last but not least, Clare Nasir, who's going to be talking about fibroids.
First of all, I probably might, like most women in my position, I think only until I was diagnosed with deep infiltrating endometriosis stage 5, a week before I had a hysterectomy, did I really realize what I'd been living with for so long. I'd been diagnosed around 2015. In fact, the week before, my team won the double, and I had a laparoscopy just to remove some endometrial tissues and stuff. And from there on in, I had experiences which was, I then had the Mirena coil, which perforated my cervix wall. So I had a really terrible experience going from getting some of the tissue out to a perforated cervix wall, to then going through IVF and trying several attempts to try and have a baby, which I was successful with in 2018, but recognizing how IVF exacerbated my endo symptoms, and then got to that end stage. And I just remember the last 5 years being absolute agony most of the time, and debilitating in so many levels, and just doing everything I possibly could. Even though we had menstrual cycle coaches at work, what I realized, there was nothing I could do in terms of just improving things from my nutrition or psychological or exercise perspective, that I absolutely needed a surgery. And now I'm left with the fallout of a 5.5 hour hysterectomy. It was the most difficult surgery that my doctor said she's ever performed, because it was absolutely everywhere. But in intubating being intubated for 5.5 hours, then they've damaged my esophageal sphincter. So now I'm dealing with silent reflux and the impact of that. So the hysterectomy has changed a lot for me, but I'm left with the realities of something else I'm having to deal with. So coffee has disappeared out of my life.
Do you wish, Emma, what advice do you wish you'd been given right at the beginning?
Well, I always go back to education. For me, it starts in school, that I needed to know more about my reproductive system, about everything from puberty to menopause. I'm an advocate of educating very early on around some of the very, very big differences that happen within our period. And there are some that don't suffer at all. We have a perfectly regular period. Some have elongated cycles, some have fibroids, some have endometriosis. The education for me is absolutely key. And then it's about strategies to do that. And then ultimately access for everybody to receive the gynecological care, whether that be in the form of a vaginal what's the word, scope, and MRIs if we needed to, instead of it just being just a period and dismissed.
Thank you. Can I go on to Andrea, because you're next on my screen at the moment? It's almost random, isn't it? And I know you've had a journey with fibroids, but what was your journey like, and what do you wish you'd been told at the beginning of it? Or perhaps you don't, perhaps you've been treated in an exemplary way.
Well, my journey's still ongoing. So I was diagnosed about 5.5 years ago. The diagnosis was quite quick for me, but the search for a treatment that works for me is still ongoing. And I think that's the biggest thing I would share with anybody, is there is no one size fits all, because a lot of the treatment options for fibroids are contraceptives, because the idea is to try and manage and control your periods, which unfortunately for me, nothing has worked for me apart from the contraceptive pill. But due to high blood pressure, I was taken off of that, and because of my age, also because of my age, and because I'd still like the opportunity to try for children, all of the surgical options are off the table for me at the moment. So I have had the implant, the injection, the pill, the mini pill, and I am now just had the coil fitted 2 weeks ago, which I was told wasn't an option. I went for a hysteroscopy to assess my feasibility for either myomectomy or embolization, and the consultant at the time just said, I think we'll try you with the coil. So it's always, you have to give it 6 months, you have to give it a year. And it's like, what my body is doing in that 6 months to a year is completely unpredictable. So I'm in no better a situation, because I could be spotting every day, I could be having really heavy days, I could have a few days where there's nothing, but I have no idea what's going on with my body. I have very little control over what's going on with my body, and that has a massive impact on me in terms of my ability to cope in social events. I'm always anxious. Is there a toilet nearby? Like, I need to know all of these things before I go anywhere. I couldn't tell you the last time I wore a pair of white trousers. I haven't been on holiday since 2018, and this is all the result of the anxieties around my heavy periods, not having any control over what my body's doing. So yeah, I think that the one thing I would share with anybody is to listen to your body, understand what is normal for your body, and if something doesn't feel right, go and speak to your GP and keep pushing until you get a resolution. Because I mean, I'm 5.5 years still pushing for a resolution, but just don't give up. If it doesn't feel right, if it's not working for you, don't let somebody else tell you that it's right for your body. Listen to what your body's telling you, will be my biggest tip for anybody.
Thank you. That's really helpful. Thank you, Andrea. And Claire, welcome. We've been talking to our ladies with lived experience who've kindly joined us, and we were wanting to know what your treatment or your diagnosis and treatment journey were like, and also how it impacted your life, like both personally and at work, if you're prepared to share that with us. And also, what advice would you like to have been given right at the start of your journey? So it's lovely to see you here, and thank you for joining us. So please feel free, the platform's yours.
Thank you. I was diagnosed with fibroids back in the early 2000s when I was just turning 30, before I got married. Right now, I have to say, if anybody approaches me about fibroids, I have a lot to say about it. And I think the support network wasn't there for me at all. And because of that, the situation pretty much escalated and got out of control, because I wasn't making informed decisions, which wasn't helped by my GP, who wasn't very good. I lived in central London at the time. And in fact, I had a number of operations, which started off with an embolization, which didn't help and didn't work and was very, very painful. And my bleeding increased to a point, I think 6 years later, I eventually had a myomectomy. So in that time, I was living in central London. I was working full time, and it was just one day after the next whether I was exhausted or whether I was hemorrhaging or in a lot of pain, particularly after the first operation, which was an embolization, which pretty much tries to cut off the blood supply to fibroids. There also was the mental sort of the pain as well. I mean, I looked 5 months pregnant for about at least a year of being on air, and people kept writing in and emailing saying, why isn't Claire declared her pregnancy? So all of these things really didn't help my mental state and my physical state. As I said, wasn't given any support or advice. I didn't really ask for much either. I didn't really know what it was. I hadn't really read up about it until I realized it was just getting out of control. And I got married during that time, and it really was just myself and my husband who sat down. We sat down together, said, how can we really sort this out? And eventually I went private with my medical care, just to sort of nip it in the bud, because it was so debilitating. So much so I'd be doing an outside broadcast. I worked at GMTV at the time, and I would, blood would be running down my legs. So I'd be bleeding for 2 weeks out of the 4 every month. When I eventually had my myomectomy, and thank goodness I did, it was life-changing for me. I wasn't able to have it initially because I was so anemic. And again, something which hadn't been checked, my iron levels were so low, I could hardly walk up the stairs without having to lie down before I came back down the stairs again. And I don't know how I held down a job, to be honest. So the myomectomy was something which, when it happened, it was a revelation to me, absolutely transformed and changed my life. But after that, I couldn't get pregnant, and I went through many fertility treatments, because, as my gynecologist said, your womb is like a battlefield, because I'd had treatment after treatment and it hadn't worked. So now when I am approached, and a friend of mine just last year told me that she had fibroids, I was able to really sit down with her and go, you have to get this sorted, because these things like aliens inside you, and they take over every aspect of your life if you're not careful, and you really have to ask for help.
Thank you very much. That's a very graphic description, and thank you. And that's what so many women tell me in the clinic, that they feel that these fibroids have taken over their lives. Absolutely. So, Caroline and Anneleise, you've heard a lot about how we've not been, meeting the demands. What do you think we can do from both sides of the house to improve this? I mean, how do we get this? And I suppose what I'm asking you really is, I'm conscious of the fact that the 2/3 of the increase in the waiting list for elective surgery is gynecological. And I find that really difficult to understand, because it's not cancer diagnoses. It seems to be thought of as people say, benign. I've also banished that word from the DH. We don't talk about benign gynecology. We talk about cancer and chronic debilitating disorders. But there's nothing benign about not being able to carry on with your life. But what else can we do? How can we get you to be advocating politically for us to get this pushed up the agenda? Because we're definitely right down at the bottom of the priorities at the moment.
Which one of us do you want to go first, Lesley? Okay, look, I'm happy to. The thing I wanted to say, and I can vividly remember this during the height of the pandemic, was talking, I think it was to the Royal College, about the danger that there was, that post-pandemic, when waiting lists would have increased because electives weren't taking place, that it would be gynecological conditions that were at the bottom of the heap. And the priority would be on cardiac and cancer, and it would be women. Let's be brutally honest, it would be women that would fall to the bottom. Look, I approach everything, and I hope Anneleise will testify to this, from the perspective of the Select Committee chair. So I don't make this political. I make this about what can I do in my job to hold the government better to account, so that they are regarding this as a priority. And I think there have been massive strides forward with the women's health strategy, with women's health hubs, with the appointment of yourself, Lesley. But it's not enough. And I'm very painfully aware of that, because every week in this role, I will hear from women, like Clare, who has just given us the most incredible and personal explanation that she was not empowered to make informed decisions. And we heard, and I'm sorry, I'm absolutely useless with names, and I put that down to menopause. We heard about, the previous speaker can't remember the last time she wore. Andrea couldn't remember the last time she was brave enough to wear white trousers. And every single one of those things is impacting on women's lives horrifically, stopping them from being able to live their lives as they wish to do. And I regard it as my job and the committee's job. And that's why we've launched this inquiry. And it's why we will be, no doubt, taking evidence from yourself and evidence from ministers and making recommendations to ministers to say, too long, women have been left at the bottom of the pile because, and I can be really horribly outspoken, and I know that, because we have had massively changed, but we've had a medical profession that is very heavily male dominated, particularly in the upper echelons of the profession. It just strikes me that we need not just a women's health strategy, we need ministers across government who are prepared to say, in the Treasury, more money for women's health, in the DHSC, more priority, more emphasis on women's health, in all of those other departments. And it's not a single government department problem. Like education, we have to make sure that from a very early age, women are empowered to know what is normal, what is not normal, are encouraged to talk about it, not, have the, we don't want to talk about women's issues moments throughout education, throughout their entire working career, because without beating down the stigma, we achieve nothing. So look, I take it on my shoulders. I know that we will have to make some serious recommendations to government and hold their feet to the fire. I always get told off for using that phrase because apparently it's too aggressive when they don't agree with our recommendations. But keep up the pressure in exactly the same way that on a cross-party basis, me and people like Carolyn Harris have kept up the pressure on the menopause.
Great. Anneleise?
Yeah, I mean, I feel that actually currently there's increasing concern about gynecological issues across the country, both because of people becoming more aware of them, although there's a lot more to do, and I'll obviously come back to that, reflecting on the powerful things that people have just said, but also because I think there is an awareness at the moment of the kind of barriers that people are having to consistently try and break through in order to get treatment. And I think that applies in relation to women's cancers actually, as well as in relation to some of the issues that we've been talking about today. You know, I was quite surprised. I've been kind of visiting different parts of the country where there are particular issues around you know, low rates of screening, for example, or indeed particularly long waiting lists. And I find huge interest and concern about that in local media. And I would say kind of 10, 20 years ago, you wouldn't have had that. Now, obviously, the situation's got more challenging around some of this. So you know, there is a longer time people have to wait. And undoubtedly, that's kind of pushing forward some of this. But I think there is now really an interest in what's going on around women's health. You know, obviously paid tribute to the work that Dame Lesley and others have been doing around this too, in kind of elevating that. So I think now is a time actually when there needs to be more of a focus. I think there's also much greater understanding of the economic impact of this. I think all of us kind of shy away from focusing on that, because clearly the biggest impact is the, you know, the often kind of moral and personal impact, the pain, the impacts on your family, on your you know, whatever plans you might have for the future, which can be radically altered. And you know, people have spoken really movingly about that, and thank you for that testimony. And the everyday impact of it obviously is the most important thing, but actually that economic impact is huge. You know, I think we need to do more actually to build up that evidence base, because I think we're kind of getting there on menopause, and it is persuading you know, some decision makers to change. But you know, certainly I find an open door when we've been pushing on, you know, kind of new policies around this as an opposition. I think we need to be getting to the same stage really when it comes to some of these issues around menstruation more generally. I then also think, just finally, that we do need to be focused on those inequalities, and this is obviously an area where exactly the same kinds of inequalities that we see everywhere in women's health are pushed into sharp relief. I mean, for example, I think there's now increased awareness about the maternal mortality gap. I mean, obviously overall maternal mortality is increasing, but we've had that stubborn gap for Black, Asian, minority ethnic women. Clearly with, you know, when we're talking about endo, PCOS, and, you know, some of the other issues around length of diagnosis for other gynecological conditions, you know, there is a structural issue there. There's a big problem there that does need to be dealt with. And in order to deal with that, I think we do need to make sure we've got the data and that we've got accountability actually around change. You know, this needs to stop being something that's nice to have, where you've got enthusiasts who are interested in it. It needs to be right at the heart of what we're requiring our health system to do. So yeah, thank you all again for that testimony, and really a lot of work that we need to be focused on together.
Now, I'm conscious of the fact that Alice Living has been able to join us, and she's only can only be with us for a short while. So before I go on to Varsha Jain to talk about research and new treatment options and medications and other interventions, Alice, you've had a real battle with polycystic ovaries, haven't you? So what I was asking the other ladies who've joined us with lived experience, who've been so generous in sharing their problem journeys with us, is what was your journey like, and what do you wish you'd been told right at the beginning of it? If you know, with that wonderful thing called the retrospectograph. So over to you. Thank you for coming.
No, thank you so much for having me. I'm so sorry I can only be here for a little bit of time as well, but I'm really grateful to be joining, and also such an incredible panel. So yeah, thank you so much for having me. I think it's brilliant that you know, just what I caught when I joined was excellent to hear. But yeah, so in my experience, I've had painful periods for as long as I can remember. And I'm talking like excruciatingly painful, like, you know, you pass out, you feel sick, you have to take days off work. Every month I'll probably take maybe 1 or 2 days off. Thankfully, I've now been prescribed much stronger painkillers, and have, you know, regular conversations with my doctor that I'm able to kind of get those. But I think what's challenging, and actually, you know, from listening to what Anneleise just said, I do feel that as great as it is to be here, I also come at it from a massively privileged position. So I don't necessarily feel that I cover, you know, a really a more common perspective when it comes to these issues. I think that I have the opportunity to be able to speak to a vast array of women in my line of work. And I guess my experience has been that, yeah, it's been really challenging. I had to see, I think, 3 different gynecologists before I was able to get a diagnosis at all. And even then it was really complex, and it was it just felt like I was kind of constantly being told that everything was fine, everything was fine, everything was fine. And, you know, pain to the extent that I was experiencing it obviously wasn't fine. So it was challenging in that sense. But, you know, when I speak to women every day and I talk about, you know, periods and menstruation and how, you know, challenging it can be, I have women that message me that are debilitated by their experiences. I mean, they, you know, cannot even, whether it's PMD, which I don't know has been mentioned, you know, serious kind of emotional and kind of challenging mental health issues around their cycle, or whether it's the pain, whether it's endo, you know, it's just, it feels like it's something that's kind of just written off because women have periods and therefore we should just learn to deal with the pain. And I think that that's something that I've always found incredibly challenging. And, you know, I'm a personal trainer by trade. I used to be a professional dancer, and, you know, pain was very much seen as something's wrong, you know, you need to do something about it. But yeah, when it comes to our periods, we seem to feel very differently about that matter. It seems to be that we're almost just writing it off because it's something that we should experience. And, you know, our womb has to contract and therefore we might get some cramping, but, you know, just, it's fine, it's normal. And so kind of deal with it. So, you know, from my background, you know, in everything that I've experienced, whether it be sport and dance, I think if this were anything else physical, you'd be, you know, signposted to a physio, you'd have treatment, you'd be very much kind of cared for in that regard. But it just feels like there's not necessarily the same pathway of care when it comes to things around our menstrual cycle. So yeah, I hope that I've added something, but I feel like I've sort of come to it late, so I don't know whether I've necessarily contributed much value. But yeah, it's brilliant to kind of be involved and to hear this conversation today, for sure.
Thank you. And thank you for agreeing to be part of our Just a Period campaign, because your input will be really valuable. Now, I'm going to move over to Varsha Jain, who is very expert in the world of medical research and who Wellbeing of Women have been funding for her research, which has been very, very productive. So, Varsha, tell us about why you think it's so important to undertake new research. And in very simple terms, and I'm not being patronising to the audience, but in very simple terms, what is it that we need to understand about menstruation if we're going to really crack these diagnostic conundrums and the bits that we haven't been good at so far?
I'm a clinical academic. I've actually just slipped away from menstrual problems clinic just to be on this call, so I've got to go back and see more patients. What I've been working on is essentially, we know that menstruation happens. We know that any change in menstruation is combined under this term abnormal uterine bleeding. And we also know that about 1 in 3 women are affected, and probably 1 in 2. So on this call, there are several women who we've got as patients who would be affected. There are probably half of the others who may have been affected at some point in their reproductive years. And I have to justify why I get research funding, but I think the lived experiences that Andrea and Claire have spoken about in terms of heavy periods really speak to what I've been talking about over the last 4 years as to why I'm doing it, how much of an impact this is having, but also why I need to justify that my research is important, because less than 3% of funding in the UK goes towards reproductive health research, which is just not enough considering how many women are being affected by this. When we think about menstruation and we think about what's happening, what my work is focusing on is that the lining of the womb is bleeding, but we don't actually know what's happening or what's changing in the lining of the womb. A lot of the medication, so we've been told that people and patients have to try different medications, wait 6 to 9 months, see if they work, and go on. And what I hate as a gynecologist is the only thing I have is a shopping list. I have to offer patients a shopping list of treatments and say, this is what's next, this is what's next. It's just not good enough. And what my work is focusing on is actually looking at those changes that are happening in the lining of the womb, trying to understand, let's break it down. We've got fibroids as a cause of heavy bleeding. We've got adenomyosis as a cause of heavy bleeding. What is changing? What is going on? So if medication A is being used, can that treat what the changes are? Or do I actually need to forget medicine A and go on to medicine B? And this has come from my background of work with female astronauts and looking at personalized healthcare for female astronauts in space. But actually, why can't I offer that to every single person that comes into my clinic? That's what we should be doing. We should be treating every single woman that comes into clinic as an individual and giving them that level of importance. And that's why this research is important. We still don't know why normal menstruation happens. We think it's because of a change of balance of the hormones, estrogen and progesterone, but those careful differences that happen at different points of the cycle, we still don't know what's normal. So how are we going to have an understanding of what's abnormal? And so that's why I think this research is really important. Medications that we have are failing. 1 in 3 women who have heavy periods have to resort to a hysterectomy because it's just what we have is just not good enough. And quite often we have to understand that heavy periods, this is a symptom, it's not a diagnosis. We've all talked about heavy, painful periods, but when we just talk about the symptom of heavy periods, we still don't know how much this costs our economy. No health economic review has been done into the pure symptom of heavy periods. We've become in the last few years a lot more comfortable talking about pain, a lot more comfortable talking about endometriosis, but fibroids, adenomyosis, very few women will talk about this. And I think we need to shine a light on it. Normalizing that conversation is vitally important. And when I was back in school, all the boys would be taken away and the girls would get the chat about what periods are. Why are we doing that? Why are we removing our boys from the conversation? All of this needs to change. And we've talked about education, we've talked about advocacy, we've talked about that idea of presenteeism versus absenteeism at work, being there but having blood running down ourselves, or not being able to actually get to work. All of these ideas, what I say to justify my work, it's nothing compared to the lived experiences of what we've heard today. New treatments are needed because what we have is just not good enough. But also, I think that we're not going to really change the landscape until we fund the research that's happening.
Thank you very much indeed. So are there any of our panel members who'd like to ask any questions of Varsha or anybody else for that matter? But she has done some extraordinary work, as she said, with the astronauts, because presumably astronauts, it's disadvantageous to bleed, isn't it, Varsha?
It is. So astronauts suppress their menstrual cycles in space. And this is actually what got me to start questioning why I can't do this for my patients here on Earth. And the astronauts are able to take the pill back to back in order to suppress menstruation, but they are a select group of very healthy women with no other medical problems. Quite often when I have patients that come into clinic, a recent study showed that there's anywhere between 6 months to 36 years before they see a medical professional for their heavy periods to actually start the ball rolling, let alone get a diagnosis as to what's causing their heavy periods to then getting a treatment that's working. It's a really long journey, and that's just too long, to be honest with you. And that's what led to my research. So the female astronauts have this unique ability to have this personalized healthcare approach to them. And that's what I was saying I wanted to take with women here on Earth.
Thank you. And for those of you who may have seen the Davina McCall expose on contraception and the pill, I think one of her comments on that's really lovely. You know, that everyone thinks that you've got to bleed every month and you don't. And when she heard that she could take the pill back to back, she felt her life was transformed. But that brings me on to another point, and that is, Nighat, if I could ask you and Pops Aziza as well, because in conversations I've had with you about how to reach those women who it's been too easy to ignore, you will tell me that there will be cultural issues about menstruation that are really important for us to understand if we want to improve this, and if we want to reinstill the trust in those women who have been too easy to ignore in the past and have got such a bad deal from the disadvantage that we've put them at. So Nighat, would you like to talk about that from a cultural or a faith point of view?
So from my work, working with women of Muslim background and Sikh and Hinduism, there's variations in regards to the myths and the beliefs around period bleeding. So if you look at sort of rural India, there is still a belief that if a woman is bleeding, then she's considered dirty, so she can't touch certain food or pray. That's also the case in Muslim groups as well. So as a Muslim woman, I'm not expected to fast. I'm not expected to go to the mosque or pray at that time. And it's also because there's a sense of this is the time when you're dirty. But that's a cultural view rather than a faith view, because in religion, it's more the fact that this is a time where a woman can recover because she. And essentially, historically, if you look at it, is because there were problems with fibroids and women were probably anemic. So the faith aspect has been that the fact that a woman is exempt from fasting at that time, and she's not expected to fast for 30 days without drink or water if she's heavily bleeding at the same time. So we need to be able to tackle some of those nuances within the understanding of women, because intrinsically, periods are linked with fertility. So not having periods means that you're infertile, which is a huge area that is taboo to talk about, but also a real fear of women losing their fertility, because you're meant to procreate, have an heir and a spare to pass on the legacy. And in Islam particularly, there is a saying within some of the scriptures that says that the role of a woman is to have multiple babies to make sure that there is furthering of Islam. So some people take that verbatim. However, for some others, like myself, I think it's more about a woman has choice. I remember when I did a work in my community in Chesham, looking at access to contraceptive services, women for whom English is not their first language, making the decision about choices around contraception, they would actually discuss that with their husband, and to a greater extreme with their mother-in-law, because of the fear that having a coil inserted meant that she would be rendered infertile, which would be the biggest shame that she could ever experience. And where is autonomy in that, within that woman? Where is the fact that, are we communicating having a pill back to back which stops her period and reassuring her about her fertility? So that is where Varsha's work in regards to giving women the empowerment of knowledge to understand what normal is, and the fact that the fertility won't be impacted if they don't have a period. That's the biggest barrier that I find from women from culture, from Muslim and ethnic backgrounds, from ethnic minority communities, is that their fear of loss of periods is greater because of the fear of loss of fertility. And we need to intrinsically have the research and the knowledge to empower women from those groups with that.
Thank you very much. Aziza, do you want to add anything there?
Yeah, absolutely. So I completely agree. You need to understand the culture. You need to understand what the myths and misconceptions are, but also, for instance, needing the medication. I sometimes have to have long conversations with my patients, for instance, about being on the combined pill, a teenager with, you know, a mother background, perhaps South Asian, even Black African. As soon as you mention the pill, nope, she's not having it. She doesn't need it because she's going to be sexually active. So it's dispelling that and trying to explain and get their understanding when it comes to why treatment can help, and then why, again, it can help her go into school, progress into school. I also think it's important, we mentioned education in youngins. So I've had teenagers who don't come in about heavy or painful periods, and their mom has to encourage them to talk about it. And it's like, no, it's fine. It's just a period. They literally use that language themselves. And then you have the discussion, you do the investigations, they're anemic, they're missing several days of school, and they don't realize that actually this isn't normal. That's not something that they should persevere with. And finally, representation. I think it's so important that you have someone who looks similar to you. The trust is there. And then you feel like, oh, actually, that condition perhaps does affect me. Because a lot of campaigns don't have many people of color. And that then makes people of color assume that has nothing to do with me. So I think it's great that this panel is quite diverse. And I hope that that continues, because it makes such a massive difference. It feels inclusive.
And I wanted to say on that point, because a lot of women's anatomy and autonomy, particularly when taking periods, the men are involved very much, to the point where even father-in-laws are involved. And that varies so much depending on the level of education within the house. So when talking about things like contraception, invariably, I found that even if a woman is, say, a very well-educated Pakistani woman, I had a barrister in my clinical room, she still said, I want to discuss this with my husband. There is this sort of feeling about fertility, promiscuity, the fact that if she is taking something like a contraceptive to stop her heavy bleeding because of fibroids, for example, that she might, be promiscuous. And then the cultural aspects of what about going to the mosque, what about having Ramadan, etc. So I think the men's role in ethnic minority communities when it comes to women's health is greater, and it's possibly very much underappreciated in the NHS clinical pathways that we have, because you've got to be able to educate the men as well. And I know that we say that a lot, but I think it plays a greater role in ethnic minority communities, because women instantly will say, I can't make the decision on my own. I need to speak to my husband.
Thank you, Nighat. It's really important points. And if I may share with the group, Nighat, you recently introduced me to your father, who is an imam, and he was a bit wary of me at the beginning of the evening, but by the end of it, we were great friends, and he invited me to go along to his mosque, not to talk to the women, but to talk to the men. So I thought, that was a real win. And so I'm hoping you're going to make that happen very soon, Nighat.
The biggest fan of Lesley, honestly. He walked away and he just said, she's a very smart woman. And I said, you have no idea, Dad.
I mean, I'll go back to Varsha's point as well. I think it's so important that the girls, young girls and boys understand what's happening with menstruation. I mean, I often end up saying, almost, I suppose I probably sound a bit exasperated to some of the women that I see in clinic. Look, you've got to understand your uterus, your womb lining has got no brain of its own. All it can do is respond to the hormones it's shown. So you don't have to have a period to know that you're fertile. And if you take your pill back to back and that relieves your menstrual problems, as soon as you stop showing the womb lining those hormones, your fertility will go back to how it was before. So but it's interesting quite how many times the women will stop when I'm saying that and say, really? And they actually think that there's something going on in the uterus that's controlling their fertility. They don't realize that it's just a blank canvas almost that responds, it builds up and it sheds in response to the cycles of hormones that it's given. So we're coming towards the end of our time. In the last 4 moments, I'm going to, or 4 minutes, because I get shouted at if I let it go over the hour. I just like to go around the room and thank everybody. And if I could just call out your names and just say, perhaps you could just give us one priority that you'd like to see happen to ensure that no girl or woman or person who menstruates is held back by their menstrual periods in the future. So just because I'm looking at the screen this way, I'm going to start with Clare Nasir.
Well, this has been really helpful. I have a 13-year-old daughter who's just started her periods, and I've been as open as I possibly can. But for me, I'd love professional insights and pathways that I can use, which will actually support her in a way which is open, but also private, because it's her choice. And so that as she goes through her puberty and then goes into her young adult life and beyond, that I can be an absolute pillar of strength for her and support her, but also she feels like she has a community around her that's doing that as well.
Great, thank you. And to that end, we'll ask the Wellbeing of Women team to make sure your daughter's on our mailing list, because there's a whole raft of videos of webinars just like this one about every aspect of women's health that she can now access on YouTube. So moving around, Aziza, you're next on my screen.
Okay, like I keep saying, education, education, education. I hope that we can keep pushing for education, and the earlier the better. And it's never too late to learn. So I hope that with the strategy, we have more of the videos, more education, more awareness. That way, knowledge is power. We can empower people with knowledge so that they can, it equips them with what they need when they go forward, when they see their doctors.
Thank you. Andrea, and I'll move on to Emma.
Definitely education, and I would say to remove the taboos around talking about periods and women's menstrual health generally.
Thank you. And Emma, you've had particular praise, haven't you, for your pioneering approach to women who are training in the football field or other forms of athletics. What would you like to do as your action point?
Practical strategies. At the end of the day, we have to live with it. So education around what you ingest, nutrition, to the best way to train in various phases of your cycle, because there's moments where certain types of training could have a positive impact and some can have a negative. I think, and the importance ultimately of the recognition of what we can control and what we can't, because I'm about performance. At the end of the day, people have to go out and perform. We can't just stop playing or stop playing in games. So we need, for me, practical strategies and guidance around supplementation too, the things that we do not get from our diet that can help us to deal with the pro-inflammatory response.
Yeah. Well, we'll make sure that that's really features in our women's health hubs within the strategy going forward.
Improving pain management and the diagnosis pathway, I think that could be made a lot better for a lot of women, and especially on the pain front. I think that conversations with GPs need to have, I guess, a slight, well, in my experience, more empathy and more understanding, and then more kind of I guess routes for understanding why the pain is happening, rather than just being told to take some painkillers and off you go. So I think, better diagnosis pathways and helping women manage their pain, because, as Emma said, we have to deal with it, and, we want to live our lives, but just more empathy and understanding on that front to kind of really manage it in a better way.
Great. Well, you'll be pleased to hear, I think, that the year 2 priorities for the strategy, which I've just sent up to the ministers, includes management of pain from common gynecological problems and managing hysteroscopies. So let's just hope that the ministers agree to them. Caroline, you can have the last word, because you've been quite quiet for a little while. So
sorry, unusual for me to be quiet. I'm just going to follow on with what you said there, Lesley, about ministers having strategies sent up to them and having to make the decisions. I want the policymakers to make sure that they're listening to women's voices. That's all. I don't think it's a big ask, is it?
No. And if you'd like me to come and talk to your select committee, I'll be there like a flash.
You will be getting an invitation, Lesley.
So can I say thank you to everybody on this platform? You've been absolutely wonderful, generous with your time, and very, very prepared to share some very personal things with our audience. And I really do appreciate it. Wellbeing of Women is the only charity that supports every aspect of women's health from cradle to grave. And we'd really like to have you amongst our regular listeners, to our watchers, to our webinars. And it's fabulous that you've all offered to be ambassadors in the way that you have for us. So thank you very, very much. And I look forward to working with you again and achieving great things. So thank you again, and bye-bye.